Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing.
Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching critical care nursing. For today's topic, we have the responses to altered ventilatory function. In this lecture video, I will be discussing the topic using the 5 phases of the nursing process, namely the assessment phase, the diagnosing phase, the planning phase, implementing phase, and lastly, the evaluating phase. In this way, we will be able to integrate the nursing process in the care of clients with altered ventilatory function in critical care settings. First, let's discuss the assessment of the ventilatory function. Correct diagnosis depends on an accurate health history and a thorough physical examination. A respiratory assessment can be done as part of a comprehensive physical examination or an examination in itself. Use judgment in determining whether all parts of the history and physical examination will be completed based on problems presented by the patient and the degree of respiratory distress. If respiratory distress is severe, only obtain pertinent information and defer a thorough assessment until the patient's condition stabilizes. In your assessment phase, we have subjective data. That includes the important health information of your patient as well as the functional health patterns. We also have the objective data. That includes the physical examination and diagnostic studies. Now let's proceed to the important health information under your subjective data. This includes the past health history. It is important to determine the frequency of upper respiratory problems such as colds, sore throats, sinus problems, and allergies, and if seasonal changes have an effect on these problems. Next is medications. Take a thorough medical history. Assess and document both prescription and over-the-counter medications. Obtain information about the reason for taking the medication, its name, the dose and frequency, length of time taken, its effect, and any side effects. Next, we have your surgery or other treatments. Determine if the patient has been hospitalized for a respiratory problem. Note the dates, therapy including surgeries, and current status of the problem. Determine if the patient has ever been intubated because of a respiratory problem. Next, let's proceed to functional health patterns. Firstly, we have the health perception, health management pattern. Ask the patient if there has been a perceived change in health status within the last several days, months, or years. Next is nutritional metabolic pattern. Weight loss is a symptom of many respiratory diseases. Determine if the weight loss was intentional and if not, if food intake is altered by anorexia for medications, fatigue from hypoxemia or increased work or breathing, feeling full quickly from lung hyperinflation or social isolation. Next is elimination pattern. Healthy elimination habits depend on the ability to reach a toilet when necessary. Activity intolerance, secondary to dyspnea, could result in incontinence. Next is we have activity exercise pattern. Determine if the patient's activity is limited by dyspnea at rest or during exercise. Next, we have sleep-rest pattern. Determine if the patient wakes up because of pulmonary problems. Also, we have cognitive perceptual pattern. Because hypoxia can cause neurologic symptoms, ask the patient about apprehension, restlessness, irritability, and memory changes, which can indicate inadequate cerebral oxygenation. Also, we have self-perception, self-concept pattern. Dyspnea limits activity, impairs ability to fulfill normal developmental role functions, and often alters self-esteem. Also, we have your role relationship pattern. Acute or chronic respiratory problems can seriously affect performance in work or other activities. Next is sexuality reproductive pattern. Most patients can continue to have satisfactory sexual relationships despite marked physical limitations. Also, we have your coping stress tolerance pattern. Dyspnea causes anxiety, and anxiety exacerbates dyspnea. The result is a vicious cycle. The patient avoids activities that causes dyspnea, becoming more deconditioned and more dyspneic. And lastly, we have value belief pattern. Determine the patient's adherence to the management regimen. Now we're done with the functional health patterns. We'll proceed with the physical examination. Vital signs including temperature, pulse, respirations, blood pressure, and oxygen saturation obtained by pulse oximetry are important data to collect before examination of the respiratory system. Physical examination has 4 techniques. We have your inspection, palpation, percussion, and auscultation. I have here common chest examination findings for common pulmonary alterations. We have your COPD or chronic obstructive pulmonary disease, asthma in exacerbation, asthma not in exacerbation, pneumonia, atelectasis, pulmonary edema, pleural effusion, and pulmonary fibrosis. Along with these common respiratory problems, we have an examination findings based on the 4 techniques of physical examination, namely inspection, palpation, percussion, and auscultation. Now we'll proceed with the diagnostic studies. First, we have your blood studies. Under your blood studies, we have your hemoglobin. This is the test that reflects amount of hemoglobin available for combination with oxygen. We use the venous blood. So for male patients, the normal range of your hemoglobin should be 13.2 to 17.3 grams per deciliter. For females, however, we have 11.7 to 16 grams per deciliter. Next, we have your hematocrit. This is the test that reflects ratio of RBCs to plasma. Increased hematocrit, which we call polycythemia, found in chronic hypoxemia. Venous blood is also used in this diagnostic or laboratory test. For the normal range for males, we have 39% to 50%. For females, we have 35% to 47%. Also, under your blood studies, we have your arterial blood gases, or your ABGs. Arterial blood is obtained through puncture of radial or femoral artery or through arterial catheter. It is performed to assess acid-base balance, ventilation status, the need for oxygen therapy, and change in oxygen therapy or change in ventilator settings. Also, we have your oximetry. This test monitors arterial or venous oxygen saturation. Probe attaches to finger, toe, earlobe, bridge of the nose for SpO2 monitoring or is contained in pulmonary artery catheter for SvO2 monitoring. It is used for intermittent or continuous monitoring and exercise testing. Now we'll proceed with the sputum studies. First, we have your culture and sensitivity. Single sputum specimen is collected in a sterile container. The purpose is to diagnose bacterial infection, select antibiotic, and evaluate treatment. This test takes about 48 to 72 hours for the results to be released. Next, we have your gram stain. Staining of sputum permits classification of bacteria into gram-negative and gram-positive types. Results guide therapy until culture and sensitivity results are obtained. Next, we have your acid-fast smear and culture. It assesses sputum for acid-fast bacilli, example, your Mycobacterium tuberculosis. A series of 3 early morning specimens is used. Next, we have your cytology. It determines presence of abnormal cells that may indicate malignant condition. Single sputum specimen is collected in special container with fixative solution. Next, we have your radiology. First is your chest x-ray, which is very common diagnostic test for respiratory problems. It is used to screen, diagnose, and evaluate changes in respiratory system. Most common views are antero-posterior or AP view and lateral view. Next is your computed tomography or your CT scan. It is performed for diagnosis of lesions difficult to assess. For example, in your mediastinum, hilum, and pleura, by conventional X-ray studies. Common types are helical or spiral CT. Usually a contrast media is used. And high-resolution CT scan, which contrast medium is not used. Spiral CT used to diagnose a pulmonary embolism. Next, we have your magnetic resonance imaging or your MRI. It is used for diagnosis of lesions difficult to assess by CT scan, for example, in the lung apex, and for distinguishing vascular from non-vascular structures. Next, we have your ventilation perfusion or your VQ. It is used to assess ventilation and perfusion of lungs. Intravenous radioisotope given to assess perfusion. For the ventilation portion, the patient inhales a radioactive gas, usually xenon or krypton, which outlines the alveoli. So for the results, normal scan shows homogeneous radioactivity. Diminished or absent radioactivity suggests lack of perfusion or airflow. And ventilation without perfusion suggests pulmonary embolism or embolus. Another one is pulmonary angiogram. It is used to visualize pulmonary vasculature and locate obstruction or pathologic conditions. Example, your pulmonary embolus. Contrast medium is injected through a catheter threaded into pulmonary artery or right side of the heart. Series of X-rays are taken after contrast medium is injected into pulmonary artery. Chest CT scan is replacing angiography as it is less invasive. Next is your positron emission tomography or your PET scan. It is used to distinguish benign and malignant pulmonary nodules. Because malignant lung cells have an increased uptake of glucose, the PET scan, which uses IV radioactive glucose preparation, can demonstrate increased uptake of glucose in malignant lung cells. Next, we have your endoscopy. First is bronchoscopy. Flexible fiber optic scope is used for diagnosis, biopsy, specimen collection, or assessment of changes. It may also be done to suction mucous plugs, lavage the lungs, or remove foreign objects. Also, we have your mediastinoscopy. Scope is inserted through a small incision in the suprasternal notch and advance into the mediastinum to inspect and biopsy lymph nodes. It is used to diagnose lung cancer, non-Hodgkin's lymphoma, granulomatous infection, and sarcoidosis. For your biopsy, we have your lung biopsy. Specimens may be obtained by transbronchial or percutaneous biopsy or via transthoracic needle aspiration or TTNA. Video-assisted thoracoscopic surgery or VATS or open lung biopsy. Transbronchial biopsy and VATS can be performed in the bronchoscopy suite. TTNA is done under CT guidance in radiology, and open lung is performed in the OR or operating room. These tests are used to obtain specimens for laboratory analysis. Next, we have your thoracentesis. It is used to obtain specimen for pleural fluid for diagnosis, to remove pleural fluid, or to instill medication. Chest X-ray is always obtained after procedure to check for pneumothorax. And lastly, we have your pulmonary function tests. It is used to evaluate lung function. It involves use of spirometer to assess air movement as patient performs prescribed respiratory maneuvers. Now we're done with the assessment phase of the nursing process. Now we'll proceed to the possible nursing diagnosis. First, we have your ineffective airway clearance related to excessive tenacious secretions. Also, we have impaired gas exchange related to activity intolerance. Third, anxiety related to breathlessness. Also, we have powerlessness related to feeling of loss of control. And high risk for ineffective therapeutic regimen and management related to lack of knowledge. Now we'll proceed to the planning phase of the nursing process. This is the planning for health restoration and maintenance, under which we have client positioning, prevention of desaturation, promoting excretion of mucous secretion, airway clearance, patient education, and optimizing oxygenation and ventilation. And lastly, preventing atelectasis. So now we'll proceed with the different alterations in ventilation. So we will be discussing about chronic obstructive pulmonary disease or your COPD, pulmonary embolism, acute respiratory failure, acute respiratory distress syndrome, or your acute lung injury. Also, we'll be discussing pneumonia and the different types of your pneumonia. We have your community-acquired pneumonia, ventilator-acquired pneumonia, and other classifications as well. We also have respiratory pandemics, pulmonary hypertension, and pneumothorax. First, let's discuss chronic obstructive pulmonary disease or the COPD. It is a preventable and treatable disease state characterized by chronic airflow limitation that is not fully reversible. The airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases, primarily caused by cigarette smoking. So we have two types of your obstructive airway diseases. First is your chronic bronchitis. Chronic bronchitis means that there is a presence of chronic productive cough for 3 months in each of 2 consecutive years in a patient in whom other causes of chronic cough have been excluded. The other one is emphysema. It is an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. Next, we have your pulmonary embolism. It is a blockage in one of the pulmonary arteries in your lungs. In most cases, pulmonary embolism is caused by blood clots that travel to the lungs from deep vein in the legs or rarely from veins in other parts of the body, such as your deep vein thrombosis. Next is acute respiratory failure. It is an inability to maintain adequate oxygenation for tissues or adequate removal of carbon dioxide from tissues. We have two classifications of your acute respiratory failure. We have your hypoxemic respiratory failure and hypercapnic respiratory failure. Your hypoxemic respiratory failure, it is also referred to as oxygenation failure because the primary problem is inadequate oxygen transfer between the alveoli and pulmonary capillary bed. It is noted when the partial pressure of your oxygen is less than 60 millimeters of mercury on 60% oxygen concentration. On the other hand, your hypercapnic respiratory failure, it is also referred as ventilatory failure because the primary problem is insufficient carbon dioxide removal. It can be noted when the partial pressure of carbon dioxide is more than 48 millimeters of mercury and the pH is less than 7.35. Now let's proceed to acute respiratory distress syndrome or your ARDS. It is a sudden and progressive form of acute respiratory failure in which the alveolar capillary membrane becomes damaged and more permeable to intravascular fluid. The alveoli fill with fluid resulting in severe dyspnea, hypoxemia, refractory to supplemental oxygen, reduced lung compliance, and diffuse pulmonary infiltrates. We use the term acute lung injury or AKI when the patient's partial pressure of oxygen or the fraction of inspired oxygen ratio is 200 to 300. On the other hand, we use the term ARDS or ARDS when the patient's partial pressure of oxygen or the fraction of inspired oxygen ratio is less than 200. Next, alteration is called your pneumonia. It is an acute inflammation of the lung parenchyma that is frequently caused by microorganisms. It is an infection that inflames your lungs' air sacs or the alveoli. The air sacs may fill up with fluid or pus, causing symptoms such as cough, fever, chills, and trouble breathing. So we have here different classifications of pneumonia. First, we have community-acquired pneumonia or CAP, a lower respiratory tract infection with onset in the community or during the first 2 days of hospitalization. The other one is hospital-acquired pneumonia or HAP. It is a pneumonia occurring 48 hours or longer after hospital admission and not incubating at the time of hospitalization. So we have other classifications of pneumonia. We have your ventilator-associated pneumonia or the VAP. It refers to pneumonia that occurs more than 48 hours after endotracheal intubation. Next is healthcare-associated pneumonia or HCAP. It is a new onset of pneumonia in a patient who was hospitalized in an acute care hospital for 2 days or longer within 90 days of the infection, or the patient resided in a long-term care facility, or the patient received recent intravenous antibiotic therapy, chemotherapy, or wound care within the past 30 days of the current infection, or if the patient attended a hospital or hemodialysis clinic. Now let's proceed to respiratory pandemics. So we have here your H1N1 or the swine flu. It is a type A influenza virus that affects pigs or the swine. It can pass to humans through contact or air contamination. Human swine flu symptoms include fever, nausea, and sore throat. Next is your severe acute respiratory syndrome or your SARS-CoV, which is first reported in 2002. It is an airborne virus and can spread through small droplets of saliva in a similar way to the cold and the influenza. SARS can also be spread indirectly via surfaces that have been touched by someone who is infected with the virus. The other one is your Middle East Respiratory Syndrome, or the MERS-CoV. It is first reported in 2012. MERS-CoV is a viral respiratory disease caused by a novel coronavirus. The Middle East Respiratory Syndrome coronavirus, or MERS-CoV, that was first identified in Saudi Arabia in 2012. It is a zoonotic virus, which means it is a virus that is transmitted between animals and people. Humans are infected through direct or indirect contact with infected dromedary camels. And lastly, we have the COVID-19, which was first reported in 2019. It is an infectious disease caused by a newly discovered coronavirus. It spreads primarily through droplets of saliva or discharge from the nose when an infected person coughs or sneezes. Next, we have your pulmonary hypertension. It is an elevated pulmonary pressures resulting from an increase in pulmonary vascular resistance to blood flow. So we have here a classification of your pulmonary hypertension, which is a primary pulmonary hypertension. It is a severe and progressive disease, and it is also characterized by mean pulmonary arterial pressure more than 25 millimeters of mercury at rest. So the normal should be between 12 and 16 millimeters of mercury, or more than 30 millimeters of mercury with exercise in the absence of demonstrable cause. The other one is your secondary pulmonary hypertension. It occurs when a primary disease causes chronic increase in pulmonary artery pressure. And lastly, we have your pneumothorax. It is an air in the pleural space. So we have two types of your pneumothorax. We have the closed pneumothorax and open pneumothorax. In your closed pneumothorax, it has no associated external wound. On the other hand, for your open pneumothorax, it occurs when air enters the pleural space through an opening in the chest wall. Now we'll proceed with the implementation phase of the nursing process. This includes the medical and surgical management, under which we have the mobilization of secretions, artificial airway management, administering oxygen therapy, mechanical ventilation, thoracic surgeries, and lung transplantation. First, let's discuss mobilization of secretions by way of airway clearance therapy and airway suctioning. First, we have your airway clearance therapy. It uses non-invasive techniques to help mobilize and remove secretions in order to improve gas exchange. It includes postural drainage and chest physiotherapy. What is chest physiotherapy? It is a form of airway clearance therapy that is generally performed by a respiratory therapist or registered nurse with a goal of clearing mucus from airways and lungs. It involves striking the lungs manually with your hands with a cupped hand. This includes the rhythmic strikes and vibrations to help loosen secretions from the airways. The respiratory therapist and registered nurse can help propel them forward by placing the patient in various positions, or we call that the postural drainage positions, using gravity. So what are the indications of chest physiotherapy? It is indicated to mobilize retained secretions so that they can be suctioned or expectorated. Such conditions are cystic fibrosis, atelectasis, bronchiectasis, foreign body obstruction, lung abscess, and neuromuscular diseases. What about the contraindications for chest physiotherapy? So if the patient has head, neck, or spinal injury, so we do not perform chest physiotherapy, as well as the patient has hemodynamic instability. If the patient has increased intracranial pressure, because this could aggravate his or her condition. Hemoptysis as well, rib fracture or frail chest, vertebral fractures, and osteoporosis. Now let's have postural drainage. It is a form of airway clearance therapy that involves placing the patient's body in various positions in order to drain secretions from the lung segments into the central airway using gravity. The secretions can be removed via cough or suctioning. So what are the indications for postural drainage? It is indicated to mobilize retained secretions so that they can be suctioned or expectorated. Such conditions include cystic fibrosis, atelectasis, bronchiectasis, and foreign body obstruction. For the contraindications for postural drainage, we have if the patient has head, neck, or spinal injury, hemodynamic instability, if the patient has increased intracranial pressure, hemoptysis, bronchopleural fistula, pulmonary edema as a result of congestive heart failure, pleural effusion, and if the patient has frail chest. So here are the postural drainage positions. So first, we have the upper lobes. So with this, we have here different segments affected by the secretions. We have your postural segment, apical segment, and anterior segments. So along with this are the indicated positions that our patient should perform in order for them to drain their secretions by the use of gravity. Also, we have your right, middle, and left lingual. So, under which we have here the right lateral and medial segments, left superior and inferior lingual segments. So, these are the areas that are affected with pulmonary secretions. And along with this are the strategies or the nursing interventions in order for our patient to drain or to remove their secretions by the use of gravity. Also, we have the lower lobes. That includes your posterior basal segment, lateral basal segment, anterior basal segment, and superior segment. So the same with other lobes that are affected with secretions. We have here the different strategies or positions that our patient should undergo in order for them to drain or remove their secretions by the use of gravity.